I'm delighted to have Professor Olsen here. Jørn is a well-known perinatal epidemiologist and reproductive epidemiologist for those who are in the field. I've always wanted him to come to Cork, and we had the opportunity for him to examine Eileen's PhD, which was done and dusted today. So congratulations to Eileen. So Jørn is a medic, but he didn't practice medicine for so long, which doesn't happen often in Ireland and the UK. He just decided to go into research. Okay, now it's working. So I was telling Jørn earlier, if somebody here in Ireland studies medicine and wants to go into research, everyone will be after them, that they are not interested in doing clinical work for the rest of their life. That happens more often in Denmark and Sweden, I think. So Jørn is the head of clinical epidemiology department in Aarhus University, but also he was the head of epidemiology in UCLA before. And I know he sits on so many councils and committees, so we are honored to have him here. And just tell you one thing before I let Jørn start, we are late already, that 6-7 years ago we were doing a study on celiac disease and pregnancy outcome in Denmark. And then I heard a comment from Jørn through one of his postdocs at the time. He said, well, it seems these guys are going to replicate our work for the past 20 years, because every time we thought about study, we found that Jørn has done it 15 years ago. So he has lots of these, the first study on a certain topic, and we keep replicating and following what he decides to do in measurement and exposures and outcomes. So thank you for being here with us, Jørn.
So thank you very much for inviting me to come and give this talk here on the Danish National Birth Cohort. So one of my hopes of this talk will be that some of you will actually be customers and start using data from our National Birth Cohort, perhaps also data from some of our other studies and registers in Denmark. So it's indeed a pleasure to be here, and I look very much forward to the collaboration that we may have in the future. So just briefly, the Danish National Birth Cohort recruited women from 1996 to 2003 in their early pregnancy for long-term follow-up, and actually here we recruited 101,000 pregnancies, not women with pregnancies, and we have about 94,000 live-born children in the study. So what I intend to talk about is to give some of the historical background behind the fetal programming theories that were emerging at that time when we started the cohort. I'll present some of the aim and the design of the birth cohort study and the data that we collect. And I'll put some emphasis on how it's possible to do longitudinal studies in Denmark using some of the national registers that are available there and available in all the Nordic countries. I'll provide some information on ownership and access to data, and keep in mind that we actually welcome users of the data source, and we provide data to China, to United States, to many countries in Europe, so it's a widespread data source. And then finally I'll give an example of the current use that we have with the data source. So of course, when it started with this fetal programming theory, and it is of course not unexpected that it's possible to modify how organ function at the time when they're formed, and now we know more about how this can be done. So if you look at the past history that went into the planning of our study and the interest in doing this study, actually this study was very important for that. So it's a study done by one of our Norwegian colleagues several years ago, and he studied mortality among middle-aged males in Norway and stratified the results based upon these regions in Norway. And what he demonstrated was that if you were born in a region of Norway with a high infant mortality, then 40 to 69 years later, you would have a high risk of dying in middle-aged life if you were born in one of these regions. If you were born in a region with a low infant mortality, the risk of dying as a middle-aged male would be much lower. So he found this striking parallel association between the risk of dying in early life correlated very strongly with the risk of dying later in life. And that was later demonstrated to also be applicable for serum cholesterol levels. So if you were born in an area of Norway, and this is coming from one of the surveys that they did in Norway, so it's a much smaller sample size, but if you were born in an area with a high infant mortality, you would tend to have a high serum cholesterol level. And we know now that Barker actually replicated these findings in the UK and showed that the link, Forsdale actually believed that the link between these mortality rates were due to social factors. So he talked about social tracking. If you were born in an area of Norway with a high infant mortality, that would tend to be a poor area of Norway, and these social factors could track throughout the lifetime. And Barker, as you all know, showed that this was related to birth weight, both for men and women, and as Barker illustrated, that this association was very strong and stronger than most of the genetic associations we have found, at least at that time. And this led to these theories of fetal programming of diseases, mainly cardiovascular diseases. So Barker, as you know, presented this idea that if you had an inappropriate maternal nutrition at the time of pregnancy, if there were dysfunction of the placenta, or if you're exposed to maternal stress, there would be a fetal growth restriction, and that could lead to this metabolic syndrome where the fetus will try to adjust to the expected conditions outside the uterus. And of course that was well known from animal studies that there's this developmental plasticity. So the circumstances around the time period of pregnancy could change the phenotypes later in life, and this would be a way to prepare the fetus for the expected outside uterine environment. And if there was a mismatch between what this expected was and what the actually outside uterine environment would be, for example, if the expected would be that there would be a shortage of food, and then they were born into an area with an abundance of food, then this adjustment to that would be inappropriate, and you have this insulin resistance syndrome. And that was later developed much further. So now we know that there are genetic factors that play a role, and they come from the past history of the population, and so based upon selection and drift in the population. We know that there are epigenetic changes that may play a role, and these epigenetic changes could be inherited, but they could also be induced by prenatal environmental factors. And again, you may have this mismatch between the prenatal environment and the postnatal environment that would lead to this inappropriate phenotype and lead to some of these adult diseases later on in life. So that is still sort of the main model that people work on, and we got this mechanism now that one of the things that could play a role would be the epigenetic changes, and these epigenetic changes could be carried on over several generations. And we know, for example, that children who are born by women who have gestational diabetes, they have been exposed to high levels of glucose, and they have a higher risk of getting diabetes themselves. They have a twofold increased risk of obesity, and they have a fourfold increased risk of metabolic syndrome, at least demonstrated in some of these studies. We also recently were informed about that being born by a woman with gestational diabetes may increase the risk of autistic spectrum disorders to some degree. And I think that one of the things that we currently are very engaged in is looking at what happens to those who are born by women with chronic diseases. We know that the pregnancy time period is getting later in life now, so women are getting older when they have their children. So in Denmark, for example, the average age of having the first child is around 30 years of age. So they're getting older, and more women have chronic diseases. And whether these chronic diseases have programming effect, we still do not know, and this is an important area for research. So we have started doing research on rheumatoid arthritis and thyroid diseases and also cardiovascular diseases, but there are many other candidates that could be studied in this respect. Another important finding at that time, this was a study published in 2004 in Nature, seemed to indicate that nutrition was of particular importance. So this is a study done among mice, where they varied the nutritional components over this time period, from the time period of pregnancy until in the early phase of life, without changing the calorie intake. So all of these actually receive the same amount of energy, but have a different structure of the diet, as illustrated by this table here. And they could demonstrate that if you look at the life expectancy among mice, that would vary from 517 days to 814 days. So you can actually manipulate life expectancy with about 20% by changing these dietary components. And of course, if that would be possible also for humans, that would have a huge impact. And this particular study actually led to a number of studies that were funded by the European Union that had the focus on looking at nutritional factors during the time period of pregnancy, and we are still waiting for data, waiting for follow-up data on these studies, and it will take some time before we know if we see anything similar to what has been demonstrated here for mice. So we know that if you have this nutritional deprivation and maternal metabolic status, similar to diabetes and gestational diabetes, we have an increased risk of metabolic disorders and cardiovascular diseases in the offspring. But we also have a number of other exposures, and I think that some of these other exposures are indeed capable of inducing fetal programming. And there have been a number of studies to heavy metals, endocrine disruptors, and other environmental factors of potential importance. And I'll present some of the results from these studies. So they may operate with this epigenetic mechanism that can be transmitted across generations, and that is, of course, a very important concern if that is right. And on the other hand, if that is true, I mean, it may be possible to prevent non-communicable diseases in adulthood if one would start very early in life. And the hope has been that if you have this prevention program starting in adult life, you may only be able to modify slightly the predicted curves of diseases in adult life. But if you start very early, then you may have a completely different trajectory for these adult diseases. I mean, that has been the hope, that you over this life course would have a much larger impact on the consequences if you start here early in life, rather than what we mainly do at present now, start later in life to improve lifestyle factors. We also know that a lack of nutrition has been an important source of diseases later in life, and we have all these studies coming from the Rotterdam famine. So in Rotterdam, there was, during the last part of the Second World War, the part of Rotterdam was occupied, and there was a severe famine among the people living there. And it has been shown by following up the children born by these women that they have a higher risk of obesity, and they also have a higher risk of schizophrenia. And a study that was actually replicated using some of the Chinese data. So if you look at the Chinese data, where you have a time period when there was famine in China and look at the children born at that time, they had a higher risk of schizophrenia. So not only metabolic disorders, but there's also mental disorders could be related to what the exposures are here in the early lifetime period. We also know that some of the environmental factors, and this is a study from the Faroe Islands, where a very large proportion, at least at that time, a very large proportion of food came from fish. About 80% of all protein came from fish. And together with fish, you have the heavy metals. So, and this is a study of methyl mercury, showing that those who had the highest level of methyl mercury in the umbilical cord samples, they performed more often with a poor performance on the psychological testing that was done when they were 7 years of age. So this early exposure could have an impact that would have impact also for their school performances later on, and at least had impact on the psychological testing. And they're trying now to replicate this finding in the Faroe Islands, where the exposure to these chemicals has been reduced substantially, hoping that these findings will not be present anymore. It may also be the case that just like actually Barker mentioned in his early studies, that exposure to severe stress during a time period of pregnancy may have this program effect on the HPA axis. So we have done a number of these studies using some of the national data on that, identifying those who have been exposed to bereavement during the time period of pregnancy and shortly before pregnancy to see if it has any impact on the offspring diseases. And this study is a study on congenital malformation among those who were exposed to this severe stress during the time period of fetal life. So this is the cranial neural crest malformations in combination. So this is a follow-up study on an earlier, actually this is the early study. We've done a follow-up study on this later on and mainly replicate the same finding now with much more statistical support. So these particular malformations did appear at a more frequent occurrence among those who had been exposed to this severe stress, that the mother had lost a close relative, lost a child or lost a husband at the time period of pregnancy. So we have looked at this model of being exposed to bereavement in this pregnancy time period, looking at now a substantial number of outcomes, and the same thing has been done here from Cork. This is another study that actually was very important. This is one of the most cited studies published in the BMJ, and showing that showing a decline in semen quality over time. So it's a study where they took a number of samples from different parts of the world and looked at the semen concentration, and could illustrate that in the 30s and the 40s, semen concentrations among normal males, so these were reference groups in different studies, were more than 100 million per ml spermatozoos. And apparently that had declined to lower levels in the 1990s, and they were so bald that they actually made a regression line using these different points of estimates they have in these different studies. And if you expand this regression line, you'll see that in 2045 you'll have the last living spermatozoa. And that was actually, it's one of the few papers that inspired to a novel. P.D. James wrote this book, The Children of Men, and that was later translated into a Hollywood movie trying to imagine what would happen when the society no longer had any future, because there are no longer any viable spermatozoas available. So this was heavily debated, and clearly I think that this was sort of exaggerating the findings to a large extent. So if you actually would say that if you have the early data points and make a line through the early data points, it would be somewhere up here, and you can make a similar line along the more recent data points, and you would have a level here. So you would have two parallel lines at different levels. And if you had presented the data like that, it would much more have indicated that you have changes in the laboratory circumstances that may explain this finding of these high concentrations in the early samples and smaller concentrations in the later samples. But in any case, that was interpreted as an indication of that we had a problem with semen quality over time, and this was declining, and this was something that we should take seriously. And clearly that's right. I mean, if we do have causes operating that reduces semen quality, we should take it seriously. And it's certainly one of the concerns we have in our study, and one of the aims that we want to study. But basically, I think that now we are in the department of epidemiology. This is not how you should do a study like this. I mean, clearly this is actually combining semen quality data from different countries, from different regions, from different populations. So if you imagine you would do that on other diseases, you can get any pattern you would like to show. I mean, if you pick data on infectious diseases coming from different time periods and different countries and different regions, you could produce any kind of pattern you would like to have. I mean, if you want to make a trend analysis, you should only vary one parameter, namely time, and then keep the data from the same population. The group behind this actually do that now. So they have, from the last 15, 16 years, had semen samples from conscripts in Denmark, and demonstrate that these produce a very flat curve. So there's no longer any decline. It's just continuing, but it's continuing at this low level of semen concentration. And it is true that the levels are low, and that may be of concern. They're much lower than what you see in animals, for example. And we know that the semen production depends on the number of Sertoli cells that are established during pregnancy and early childhood. And what affects this number of Sertoli cells is still not known. We know that there are prenatal exposures that may play a role, like smoking and obesity, and are actually being used now in infertility clinics. So if you seek infertility treatment in Denmark and you have a low sperm concentration, you are asked to stop smoking and you are asked to lose weight. Okay, so this idea that diseases develop over the life course with different risk indicators playing a role at different points in time, I think it's pretty well established. Here we have the breast cancer, where we know that there are prenatal factors like birth size that play a role. We know that the growth during childhood plays a role. The age of menarche plays a role. The age of the first birth plays a role. Parity plays a role. The age of menopause and body size plays a role. So all of these exposures during the life course probably play a role for that, and that may be the same picture we would see for other diseases as well. So given this background, we decided that we would move into a study looking at the fetal origins of adult diseases. And as you can see here, that one of the editorials coming out after a meeting in India with David Barker, and the editor was very enthusiastic when he came back from this meeting and said that this is no longer just a hypothesis and may be critically important in South Asia. So he was thinking about the South Asian population that had been under nutritional deprivation during the time period of pregnancy and now lived in an area where there often was an abundance of food, and they may be candidate to being programmed to adult diseases later on. So we decided that we would start the National Birth Cohort. The original idea was actually that we would do it in all the Nordic countries, and that means that Norway, Finland, Sweden, Denmark should each collect a cohort of 100,000 newborns in the cohort, and Iceland should produce 50,000 newborns in the cohort, and we should base this upon a common data collection procedures, and that did not really work out. So we had a number of meetings, and there was also some support of doing that, but at the end it was only the Norwegian and the Danish cohort that were established at that time. So we said the background for doing that, why should we do this in Denmark? We said, well, we should do that in Denmark because we need large population-based studies. We need it especially for doing gene-environment interactions. At that time there was a great hope that the genetic studies would produce information on genetic factors that could be used in gene-environment interaction studies, which would make the environmental factors and the social factors much more visible. So if you could stratify the population according to their genetic susceptibility, we would have a much better possibility of identifying these preventable factors. We said that we should do this in Nordic countries because we have this good possibility for tracing cohort members. So all of you, I guess, probably know that all the Nordic countries have this unique personal identification number, tentative identification number, that's being used in all registers, private and public registers, and it makes it very simple and very easy to trace cohort members over time. We have an abundance of health registers, and I'll come back to that later on. But we need a register of exposure data in intrauterine life and in early childhood. And if we had such an exposure register, we would have new opportunities for doing research. At that time, it was also at least being discussed whether there were options for doing epigenetic studies and whether that could be done with some of the data that were, some of the biological samples that were available at that time was being debated, and now we know that it is in fact possible to do that. So we went ahead in 1996, and after a debate, actually a pretty heavy debate, so some of our colleagues, especially the general practitioners, were very much against this study, and we wanted to recruit the women through their general practitioners because they see the pregnant women first in Denmark, so they are the gatekeepers to the whole system. So once they come with their pregnancy to the general practitioners, they are recruited to the antenatal care system. So we wanted to use them, and about 50% of all the GPs actually accepted to take part in this recruitment and invited their pregnant women to go into this study at the first pregnancy visit, and about 60% of those who were invited accepted the invitation. And it actually turns out that although there was a huge resistance in the beginning against going into this study, the GPs that we did recruit were very loyal to the project and actually continued. And it turned out to be of no real concern. They were very much afraid that these interviews that we were running would cause a lot of alarm, and they would call them all the time and ask questions about different things, and that never really didn't happen. So it actually went pretty fine. So we've recruited about 30% of the entire group of pregnant women in the country at that time. So it's clearly not a representative sample that we have in our study. And I think that was something that was heavily debated. So you probably know about the National Children's Study in the United States that was debated and planned to be established about at the same time, or a bit later than the Danish National Study, that had a budget of, to begin with, $8 to $9 billion to do this study, and turned out to be not feasible to do in the United States for many different reasons, which really is a pity. So we collect data on three different domains. We have data on exposures and outcome. So were mainly interested in lifestyle factors, diet, several dietary questionnaires applied. We were interested in social conditions and infections and medications and also in environmental exposures. The reason that we wanted to recruit them early in pregnancy was, of course, to reduce recall bias, but also because we were interested in getting information on infections early on, and also to be able to document these infections by having biological samples at that time. So we collected biological data in a pretty inexpensive way, and I think that we would do that in a different way. We would have done it had we had more money to do it at that time. But now we just have a blood sample taken from the mother twice during pregnancy, and a blood sample taken from the child or taken from the umbilical cord at the time of delivery. And we store all of these in freezers and liquid nitrogen tanks. And the third argument we used for doing this was that we have data from existing registers, actually an abundance of existing registers that could supply the data that we collected in the National Children's Study to get data on outcomes. So this is the data collection procedure we have. So we have a blood sample taken at this first visit at the GP's office in the first trimester, but we only have 5 milliliters of blood taken that time, and it was actually sent by regular mail to the state semen to their biobank. The same was true for the second blood sample taken also by the GPs in the second trimester, also sent to the biobank in Copenhagen. And the third blood sample was taken from the umbilical cord after the time of delivery. So then we had a number of interviews. So we actually ran these computer-assisted interviews in the 12-week of pregnancy, 30-week of pregnancy, and when the child was 6 months and 18 months of age. And then we went over to using questionnaires data and collected data on the questionnaires when they were 7 years of age. And now we use this internet-based questionnaires. We used that when they were 11 years of age. We collected data when they were 14 years of age. And one of the big things now in the study is to get precise data on the time of puberty. So we are sending out short questionnaires on the Tanner stages by using smartphones to the children when they reach 11 years of age and up to their reach 18 years of age to get timing on puberty as exact as possible. And we also plan now to collect semen samples when they are reaching 18 and a half years of age. We just started the data collection for 18 years of age, so that was recently started, and we're using here again the internet and smartphone and also other electronic systems. And we are about to start these semen samples, so we need to get permission to do that, and we also need to get the necessary funding to do that, but we're in the process of doing that. So here are the total numbers of responders. So we have the starting point of a little more than 100,000, and then you'll see that not all respond to the data collection points. So it's possible for the participants actually to leave the cohort at any point in time. So if they are not happy with the way the cohort is being conducted, they can leave the cohort at any point in time. Very few do that, but quite a large number actually do not respond to our questionnaires, but are willing to see a new questionnaire and decide on whether they will respond to that or not. So response rates in this cohort is declining just like our response rate in the national surveys and in other data collection procedures that are being done in Denmark. And if we would try to see if we can identify, all that have all 3 blood samples, so if you want to follow, for example, the development of a toxic substance over the first blood sample until the umbilical cord blood, or development of antibodies, then you'll see that we only have 45,000 and we have all 3 blood samples available. So that is clearly one of the limitations, and one of the limitations that we have to accept. But the good thing is that for the entire cohort we have an abundance of data based upon the other registers that we have. So you see there have been some debates here in I think this is from Science. I think both of these are from Science. So when the entire country is a cohort that everybody can be followed over time, and we can add information from some of the other information systems we have to this cohort, then we have completed follow-up for a number of issues that we take an interest in. So that there has been a lot of interest in being able to do that, and one of the reasons I think for the US study to be so extremely expensive as it was that they did not have or they do not have these information systems available. So we now have registers in Denmark that cover 3 to 5 decades. So we actually, what we do is that we link the data we have in the national cohort, and we link that to the population-based registers for the entire country. So we have complete data on everybody in the cohort concerning all the data where we have registers, meaning that we have a number of birth characteristics from the birth registration. We have diseases coming from the hospital registration system, and a number of other specific registers. We have prescribed medication for the entire time period in this cohort. So all prescribed medication is routinely linked to the National Birth Cohort. We have data on vaccinations. We have data on child health care facilities, and data on school performances. And we have data on place of living, and we also have actually a lot of data on occupational exposures that are not mentioned here, but occupational exposures and social support, education, employment, and so on. And we have other biological specimens than just the data we collected in the cohort. So everybody, almost everybody in the country actually store their blood sample taken at the age of 5 days. So the blood sample taken shortly after birth in order to do genetic screening. It only uses a small part of that blood sample, and the rest is being stored in the biobank in the State Semen Institute, and that can be used for our cohort as well, and has been used for our cohort. So this personal identification number, the so-called CPR number, links a lot of information that's available in the country. And one of the things that is now being increasingly available will be not only registers on diseases and occupations and social conditions, but also data from the biological screening and in diagnostic procedures. So the data that will be available from the laboratories and from the X-ray departments and the scanning departments will be available also for research and can be linked to this cohort using the CPR number. And it's actually the department I'm working at now at the Clinical Epidemiology that has this responsibility of building up this information system using this biological data from the clinical laboratories throughout the country. So this is just to illustrate that, for example, the National Drug Prescription Register will provide, so whenever you buy a drug at the pharmacy, within a few seconds that information will be transformed to the center of the information system here and linked into the prescription register and can be used for research. And that has actually been very useful, and one of the good arguments for using this data to the benefit of the people is that we lack information on medicine taken during pregnancy. We lack information on the possible side effects of medication taken during the time period of pregnancy. And it's actually one of the most frequently asked questions to the healthcare system is this particular drug safe to use during the time period of pregnancy? And being able to link these prescription data with the other data sources we have, a number of studies have been produced showing that a number of drugs also are pretty safe to use during the time period of pregnancy, and are certainly safer to use than having the untreated diseases present. I'll just end up with, this is just to illustrate that this is our national biobank located in the State Semen Institute, where these samples from the National Birth Cohort are stored. And before we go to the example, just illustrate that this is an open data source. The Danish National Birth Cohort is an open data source. It has a management group that takes care of daily matters in the programs, and I'm heading that management group. But I think what is more important is that access to data is actually given by the steering committee, which is a totally independent committee from the management group. So none of us, except me actually, but none of the other ones have a place in this steering committee, and it's headed by Niels Strandberg. So this is actually a committee being established by the funding agency. So the funders of this study that put a lot of emphasis on that this should be an open data source that should be available for other researchers, have their representatives in this steering committee, and they provide access to the data. And in fact, they have said no to very few of these applications for getting access to data. One of the things that we take care of is that it's not that we are sending data out of the country. We actually place data in Statistics Denmark, and then we provide access to the data from outside. So it really doesn't matter. There's no need to have your data in Cork. You can have it placed in Copenhagen National Computer System in Statistics Denmark, and then you can get access to the data from outside. So it works fine. We have several people from the United States, we have even people from China, and from many other countries, Australia, working with the data, and it seems to work fine. And there are some further advantages of this. So if you're interested in this is the website address of the National Birth Cohort, and you can request an application form there, and within 3 to 4 weeks you can expect to get a response of whether you have received access to data. There's no cost involved in that except the actual cost. So it's only the cost involved in extracting data and putting it on the server and so on that we charge. So otherwise it's without any cost. So let me just end up with an illustration of what we can actually use this data for, because that's something we are doing right now. So you know that paracetamol, acetaminophen as it's called in the United States, is a common painkiller. It's probably also here in Ireland sold over the counter and sold in supermarkets and places like that. It's considered to be a completely safe drug to take if it's taken in the recommended doses. We all know that it's actually a pretty nasty drug if you take it in large doses. So people who are trying to commit suicide by taking paracetamol have a severe disease following often have a severe disease following that. But if it's taken in recommended doses, it's considered to be completely safe. There's no warning signals in the packages, and it's also considered to be safe for pregnant women. And I think it's true that if you look at, we've done studies on that, if you look at paracetamol taken during pregnancy, it's not related to congenital malformations, it's not related to preterm birth or low birth weight and some of the normal things we look at. So in that respect, some of the normal side effects that you see of drug, you don't really see for this particular drug. So in that way, it seems to be pretty safe. What we wanted to look at was some other endpoints than congenital malformations, and we wanted to look at behavioral problems and hyperkinetic disorders. And the reason for doing that, so we know that this is widely used. It's used by half of all the pregnant women in our sample and most other samples I've seen. So about half of all pregnant women actually take this drug at some point in time during pregnancy, and some take it at several points in time during pregnancy. It's a major ingredient in a number of drugs. Not in Denmark though. We don't have this tradition of combining different drugs together, but that's the case in many other countries. And the FDA in the US have said that this side effects are mild to non-existing in recommended doses also for pregnant women. I thought I had a slide on. Okay, maybe that comes later on. But the reason that we want to take an interest in this is that it turns out that it actually most likely had hormonal disruptor effect, and that may be of interest. So one of the first studies we did was the study on ADHD, or hyperkinetic disorder as it has been called in the past in Denmark, which is the most common neurobehavioral disease in childhood, with a prevalence about 3 to 5%, and it's prevalent, worldwide. It's all the countries that has been studied have shown that it has this prevalence of about this 3 to 5%. It's characterized by inattention, hyperactivity, and impulsivity that are the key behaviors in ADHD. It's mainly diagnosed when the children reach school ages, up to 7, 9, 10 years of age. And if they are hospitalized, only part of the children with this disease are hospitalized. In Denmark, they are hospitalized with this hyperkinetic disorder. That's not exactly similar to the ADHD that we work with now, but it's a similar disorder with a more emphasis on hyperactivity than in the ADHD. We know that it is increasing in the past decade in prevalence, partly though because it's diagnosed at a younger age, just like autism is diagnosed at a younger age, and that explains part of the treatment, but part of the increase, but also because of an increased awareness of this, and there's no question about that part of the increase is not real. It's related to changes in diagnostic criteria, and it's still a matter of debate whether it actually is increasing in real incidence over time. Okay, here it comes. So here are the reasons for taking interest in that. So it may be something that interferes with maternal hormones during the fetal development. We know that it has these endocrine disruptive properties in rainbow trouts. We know that it has structures similar to what we see in other endocrine disrupting chemicals, and actually more so than we see in many of the other endocrine disrupting chemicals, as published here in 2011. And we had a small study showing that apparently this increases the risk of cryptorchidism if boys are being exposed to this early in pregnancy, which would indicate that it may have these hormonal disrupting properties. We know that it crossed the placenta barrier, exposing the developing brain, and we know that it may have these neurotoxic effects through inducing oxidative stress, leading to neural death, as seen in some animal studies. So I think that there are some good arguments for doing a study in this. So we went ahead and did a study with the hypothesis that prenatal exposure to paracetamol increased the risk of developing ADHD-like behavioral problems or hyperkinetic disorders in children. And we used the study population of 64,000 liveborns and mothers enrolled in the Danish National Cohort. And the reason for that lower number is that we actually wanted them to have responded to all the questions we have on this particular intake of this particular drug. So this is something that we cannot get from the prescription register because it's over-the-counter drug. It's an over-the-counter drug. So only a very few, less than 2% of our women had received prescriptions for this particular drug, which is possible to get in Denmark if you are heavy users, but most of the users are really over-the-counter users and use this drug for minor complaints. So these are the data we have for use of medication during the time period and even before pregnancy. So when they are recruited, they have an enrollment form where we ask about use of medication and use of vitamins before they became pregnant and the early phase of pregnancy. And then we had this first interview when they were about 12 weeks of age, where we had detailed questions related to use of medication, and we repeated that at week 30, and we also repeated it when they were 6 months old, trying to recall what happened late in pregnancy. So we needed to have all these questionnaires available, and that's why we had this reduced number. So these are the data we used for this particular study. So the exposure assessment was the paracetamol used during pregnancy, as assessed by these 3 telephone interviews and when they were 6 months of age. And the outcome data, we used the ADHD-like behavior when they were 7 years of age. So we had a strength and difficulty questionnaire. The STQ questionnaire was filled out by the parents when they were 7 years of age. And then we had the hospital diagnosing for hyperkinetic disorder, so if they had been hospitalized as an inpatient or outpatient receiving that diagnosing, it was recorded in our project. And then we looked at those who received ADHD medication, and at that time it was mainly Ritalin that was used for treating this disease. So these were the outcome data we had available. So what we looked at was the ever use of this drug versus never use of paracetamol during the entire pregnancy, used by trimesters, and the total weeks of use during the entire time period of pregnancy. And these are, this is a pretty rich data source, so we have the opportunity to adjust for a number of potential confounding factors, and especially of importance in these studies will be the mother's reports the mother's reports of psychiatric diseases that played a great role in the adjustment. So there's clearly a family trait in these diseases, and it's important to adjust for that to the extent that this is possible. Then we also had the indications for use of paracetamol, whether it was muscular or joint diseases, fever, and inflammation or infections. And then, of course, for some of these data sources, we did not have complete data, so we used the possibility to do multiple imputations. But it was not a large number of missing data. We actually had pretty complete data for those who took part in the study, so it was about 5% of the participants who had at least one missing value for some of these covariates. So here are the results. So if you look at the use in this particular situation, it's the result of the STQ questionnaire. So here you have the overall behavioral problems with an estimate of something like between 1.1 and 1.2. And if you take the emotional symptoms that you have here, it's less. If you take conduct problems, it's a bit higher. Hyperactivity a bit higher. And then if you take the peer problems and pro-social behavior, which are not really part of the STQ questionnaire, it's lower and actually very close to the null values. So some indication of an association, which becomes a little bit stronger if you look at the it actually becomes a little bit stronger if you look at the total use. Here is the results looking at hospital diagnosing by trimester, and again you have estimates that are above 1, and if you could combine some of these trimesters, and if you look at those who take the drug in all 3 trimesters, there was a relative risk of 1.6. And again, if you look at those response-like curves to see how frequently they have used this drug over the time period of pregnancy, so if they used it for more than 6 to 10 weeks, or 11 to 20 weeks, or more than 20 weeks, you see an association that that is of some concern. I mean, this is a very frequently used drug, and this is a frequently outcome. And if they are causally associated, it's clearly something that we should be concerned about. This is actually the dose response analysis, including also a value for the trend association. And then we did a number of sensitivity analysis, and like you should do now, and the results were pretty stable to all these different manipulations of data. You could consider the strength. I mean, it's a large cohort. It has a long-term follow-up period. We have prospective data with multiple interviews, and I think the important issue is that when you have prospective data, the confounding by indication may not be all that important if you are not looking at the indication, but actually looking at side effects related to the drug taken. We had multiple endpoints to assess the different levels of ADHD, and of course you also have a number of limitations, and clearly some of the associations we find, including all the associations we find, could of course possibly be result of uncontrolled confounding factors by indication or by other factors. So I think it's very important that we will see if this will be replicated in other studies, and so far there have been a number of other studies that seem to imply that they can replicate these findings. So whether the exposure is frequent and this association may explain part of the increasing incidence of ADHD, but clearly further studies are needed. And just briefly, I'll just mention that we are doing a similar study now with the ASD, the autism spectrum disorders, and find rather similar results for this more rare and more serious disease. And finally, we're also looking at, in a subset of the data, with about 1,500 children in the study, we have rather detailed psychological testing results. So we had the ability to look at the exposure to paracetamol and IQ among the children. So in this subset of the study, which is not the entire cohort, but only this lifestyle study that was done when they were 5 years of age. So when they were 5 years of age, we selected about 3,400 women and children invited to participate in an intensive study where they would perform psychological testing on the mothers as well as on the children. And it was the main interest in this particular study was actually to look at alcohol exposure during the time period of pregnancy. But the study would allow also to use to look at other exposures. So here are the psychological test results that we applied, a large number of psychological test results, and in this particular study I'm going to talk about the IQ testing, that was applied to the mothers as well as to the children. So we did an analysis where we looked at ever versus never use of paracetamol during the entire pregnancy and use by trimester and total weeks of use just like before, and looked at these IQ scores. And we used this inverse probability weighting to account for this sampling that had taken place in the study, because the study was originally planned to be done in relation to alcohol exposure. We clearly saw that this is a selected sample. I mean, mothers of a lower socioeconomic status and children born preterm were less likely to participate in this lifestyle project. Mothers eating more organic foods and also mothers of better education are more likely to participate in this study. So clearly there are not only confounders but also forces of selection that should be taken into consideration. use of paracetamol, however, was not related to participating in these lifestyle studies. And just ending up here with the main results of this particular study indicating that both the use of paracetamol and fever were associated with a lower IQ among those who were exposed to either fever or use of paracetamol. And perhaps of some interest that if they were exposed to fever and took paracetamol, part of that side effect seems to be reduced, if not eliminated. So again, you have to take into consideration this as a number of limitations, and I think the most important of these, of course, would be the possibility of uncontrolled confounding, but also other factors that play a role for underestimating the effect, especially that the measurement of IQ at the age of 5 has a great variability. It very much depends upon how close contact the psychologist can make to the child. And since that is unrelated to the exposure, this will tend to bias the results towards no finding. But in the case that we found that use of paracetamol and maternal fever was associated with a reduction in the IQ scores, and taking paracetamol among those who had fever seemed to have a beneficial effect. And again, the associations are small, so a 2 to 4 point reduction in IQ will probably have very little consequences for the child and the family as such. But if it applies to the level of the society, with an exposure that affects about 50% of all pregnant women, it is really something of concern, since we can use all the IQ points that we can get. So then Ali also asked me to just mention a few things of what are the lessons we have learned in this cohort. And I think one of the lessons is clearly that if you make a cohort of a general type, make it large. And actually 100,000 is a small cohort. It's very important to keep the planning period short. I mean, there's so many interest involved in setting up these cohorts that if the planning period is long, then it becomes very complicated to reach agreements. And therefore you also need to keep the organization group small, and you have to provide frequent and updated information to the cohort members. So we actually send out newsletters to all the cohort members, and we have a website that produces results from all the findings we have. And then I think it's important that you accept this right to be forgotten, that people who are not interested in taking part in the study should be allowed to leave the cohort entirely and have this right to be forgotten. And just to mention that this is a study mainly done with colleagues from the UCLA, and here are the people at UCLA taking part in this particular study. And again, just to remember, this is the website, and if you want to get access to the data, this is the website you should contact. So thank you very much for your attention.
We might have time for one or two questions if anyone wants to ask anything.
So just a brief comment. It's both inspiring and, from the Irish perspective, slightly depressing to see how much has been achieved here, and particularly the way in Denmark that a level of data linkage that would be inconceivable in this country is accepted as normal practice. And I suppose I'm just wondering if anyone has had an opportunity to quantify the overall societal benefits of this work for Denmark, because I think that would be very helpful in making the case for similar projects elsewhere.
Yeah, I think that it would be difficult to estimate what the benefits would have been. I think one of the things that you could look at would be something like what is the cost of a publication, for example, in a cohort of this particular type. I mean, you probably remember when the UK Biobank was set up, there was a huge debate on whether you should spend the money on a particular set of case control studies with a specific focus, or you should set up this UK Biobank. And I think that one of the arguments was that if you set up a general cohort study or biobank, the cost per publication or the cost per finding would be less than it would be in a specific study. So I think that the cost-benefit ratio is positive if you look at the research. But of course, if you look, you should look at what is the benefit to the society, and I think that actually the benefits are large, and I think that for example the medication issue. One of the important factors of this is really that we don't have any information on medication taken during pregnancy. So you release drugs in the market that have not been tested in pregnant women or been tested in children. So they all come out with this warning that this should not be used in pregnancy unless you have to use it. And this is one of the most frequent problems you have in clinical practice, that you don't really know if the benefits outweigh the side effects. And I think that these studies, including the Organisers, have been very useful in getting that information. So I should mention that I know that this is not possible to do in Ireland. And we actually feared that it would not be possible to do in Europe altogether. So you probably know that we are getting a new set of regulation on data protection for the European Union. And the European Union developed 3 different proposals for a new regulation on data protection. And the Parliament's version of the regulation for data protection was very, very strict. So basically the rule is that you cannot use sensitive data without informed consent. So that's the basic rule, and that's been the basic rule since the days of the Nuremberg trial. And then you have to work on exemptions. And these exemptions have been interpreted in a way that the health of the nation should be at stake, before you can open this data file and actually use that. On one end, and then you had the Nordic approach that if it could be useful for public health in general, you should use this information that you have available. And so many of us feared that the new regulation on data protection, which actually will be decided upon by Brussels, so it will be a data protection agency office located in Brussels, that they would take a much more restrictive point of view concerning using this data. It turns out now that they will probably leave that for national legislation. So they will take the research use of this data out of the regulation on data protection and leave that for national authorities. And I think that among the public, and certainly also among politicians in the Nordic countries, there have been so much benefit. Actually, some of the strongest supporters of use of data for research have been the patient organizations. And I think that cancer patients, for example, have benefited greatly by the comparisons that are routinely made between the Nordic countries, clearly showing that some countries are lagging behind, actually mainly Denmark lagging behind some of the quality control indicators. And that has led to major improvements in cancer treatment in Denmark. I don't think that we have any examples that these data have been used in a way that the public has been very much against that. But of course, that's one of the things that this external committee looks at, that we have, if it could harm the environment for using data for research.
Yep.
Hi, thank you very much for this wonderful presentation. We've got a birth cohort here in Ireland. It's a much smaller birth cohort. It's 1% of the size of yours. But we don't have, as Ivan pointed out, we don't have an ability to cross-reference different data because the electronic registers are at a very premature stage of development. But my question is in relation to the biobank. I mean, you're accessing data based on your service in Copenhagen, but what about accessing samples? If somebody has a submission and a research idea that they would like to, for instance, test a hypothesis in your massive biobank, do you wish for people to do the analysis then within a Danish-based centre, or how does that work?
We actually send out samples to many different laboratories in the world, so not necessarily. We take into consideration that it's a high quality lab.
Yes,
but if that is okay, that's fine. So we can do that. Yeah.
Maybe one final question. Anyone? Perfect.
Okay.
Thank you very much,
Thank you.
Professor Olsen.